Okay. So my screen share is green. Does that mean I'm sharing?
Hang
I think
on.
now I am.
There we go.
Yep, now we can see your screen. So we'll do a quick introduction first,
Cool.
Dr. Kneller,
Absolutely.
and then we will get started.
And we're now live streaming on Facebook.
Okay, that's awesome. I don't know if anybody can see me. I can't see me, but that's okay. So what an honor. So we are so fortunate to have Dr. Kneller here to chat with us today. We're going to do a couple of quick things. Before I introduce Dr. Kneller, we're going to ask that right now everybody just stays muted, just so that we can go ahead and really focus on the presentation. We're going to honor Dr. Kneller's time by keeping this to 1 hour, and you will have opportunity to ask questions. At that point, we can unmute you if you raise your hand, or you can actually use the chat below and we can call you out or ask questions on your behalf. So that's fantastic. We're really thrilled. So Dr. James Kneller is a multitude of things. I consider him to be a friend, which is an honor. He is also one of the nation's leading heart rhythm specialists. He is certified by the American Board of Internal Medicine and clinical cardiology. In clinical cardiac electrophysiology, cardiovascular disease, internal medicine. He's a fellow of the Heart Rhythm Society, certified cardiac device specialist. He provides amazing comprehensive patient care. Undoubtedly has some of the best medical practices in North America. He is a concierge doctor, private doctor to people who are looking for additional unique medical and health related holistic care. So it really brings a brilliant service to our team, and we're delighted to have him. He has extensive knowledge, particularly in the areas of health and holistic health and how that actually affects our body from a medical and scientific perspective. So talking about omegas tonight and is really exciting. So I'm thrilled to have you. We're going to just go right ahead, and I'll turn the floor over to Dr. Kneller.
Wow, thank you, Rayleigh. That's a hard act to follow, and you look great, by the way. So thank you for having me. I'm by profession, I'm more of a heart rhythm specialist than a cardiologist treating atherosclerosis, but all of us deal with this constantly, and our patients have multiple problems, and we all have to take responsibility for these things. So I developed my own perspective on fat, cholesterol, and atherosclerotic cardiovascular disease. You know, we need to be able to think quickly and be practical in a busy clinical environment. And I thought today would be helpful, and you would appreciate it if I just led you through a cardiologist's very high level thought process on the dilemma we have about fats, cholesterol, and the consequences of those things, which is, of course, atherosclerotic cardiovascular disease, which could refer to blockages in the arteries of your heart, in the peripheral arteries of your extremities, and very importantly, in the arteries of the head and neck, which could predispose you to stroke. Okay. So I'm just looking for how to advance oh, there we go. It's advancing. So I'm on social media. Please follow me, comment, get back to me through social media if you care to at all. I have a website. It's always James Kneller, MD, all one word. So I'm on Facebook, YouTube, Instagram, and Twitter. I'd love to hear from you. And I do try to provide knowledge and tips and information quite frequently on these channels. So see you all on social media. So high level overview. What is your cardiologist thinking when you walk into the office? I think the thing that we can immediately notice is a patient's level of obesity. And of course, the question we're asking, especially in a new visit, is does this patient have atherosclerotic cardiovascular disease, blockages in the arteries of their heart, brain, or extremities, as we have discussed? So if the answer is yes, or we already know that, then my concern becomes, what is the severity of that, and how can I control or minimize the cardiovascular disease? If the answer is no, they don't have known disease, or we don't know if they have disease, then I'm worried about the risk of them developing cardiovascular disease. And so I'll think of things like their age, comorbidities like hypertension, diabetes, inflammatory conditions that may be present like arthritis, fibromyalgia. We think about family history, obesity, and try to come up with some guesstimate of the likelihood of cardiovascular disease being present. Then we can go on to testing, for example. We will do blood tests. And very interestingly, about the only thing relevant to this question that we can test in your blood is your cholesterol panel. We always do standard cholesterol panels. There's some role for advanced cholesterol panels, but in point of fact, those don't get used very often. And we have a hard time using that information in a unique way, which is part of the reason why it isn't done. And then, of course, many of you have cardiologists. We can go on to functional testing. We can do stress testing. We can do perfusion imaging, visualize the blood flow patterns of your heart, look for evidence of obstruction or flow limitation, especially when you're exercising or exerting yourself. Or we can take more of an anatomic approach and just go looking for blockages. And we can do that by measuring coronary calcium, performing CT angiography or taking CT images of the blood vessels, or even performing a diagnostic angiogram where we'll inject dye into the coronary arteries and actually visualize them directly for any evidence of obstruction. So it's all about, do you have disease? If you do, how are we treating it? If you don't, how do we explore these things? And your entire health profile weighing in on our opinion of you. So again, what is atherosclerotic cardiovascular disease? This is cholesterol or lipid deposits in your arteries. It can be the arteries of your heart, then it's called coronary disease. Arteries of your extremities, then it's called peripheral vascular disease. And what isn't shown here is in your head and neck, where atherosclerosis can then predispose to stroke. So we're really in the business of minimizing the risk of stroke, minimizing the risk of heart attacks, treating those things when they do occur, and minimizing or treating the presence or the risk of peripheral vascular disease in your extremities. And again, quick and easy, looking at you, we'll guesstimate your obesity, and usually your body mass index gets calculated as part of our electronic medical records. It's your weight measured in kilograms divided by your height measured in meters squared. So this is a gross estimate of your body composition. If you have a BMI that's between 18.5 and 25, that's normal range. If you are less than 18.5, we'll call you underweight. If you're 25 to 30, we'll say, okay, now you're overweight. 30 to 35, you're frankly obese. And above 35, we will call you morbidly obese. And these are patients who are often coming to us for gastric bypass, things of this nature, because the weight has just gotten completely out of control. Whatever the degree of obesity is, this is a problem of fat that your body has accumulated. And we'd like to minimize that and maybe take a little bit of a deeper dive into what exactly that fat is. So you ask, what is fat? So fat is chains of carbon molecules with hydrogen ions attached to them. Okay, long chains of carbon atoms, which tend to have an oxygen atom at their ends, and they may be grouped into clusters of 3, which then form a triglyceride, which is how these things float around in your bloodstream. So if there is just one bond between the 2 carbon atoms and all the rest is occupied by hydrogen, we will call that fat a saturated fat, meaning the carbon chain is completely saturated with hydrogen. There's as much hydrogen as that carbon can possibly bear. If there's double bonds between some of the carbon atoms, we will call that an unsaturated fat. If it's just between 2 carbon atoms, we'll say it's monounsaturated. It's only unsaturated in one location. But if there's double bonds scattered throughout the carbon chain, now there is less ability for hydrogen to bond to the carbon atom, and we will call that polyunsaturated, meaning it's unsaturated in many locations. So you'll hear these terms tossed around in discussions about lipids and fats, and that's all it refers to is the amount of hydrogen that's bound to a long carbon chain, and we'll see that those seemingly very subtle differences have vast implications for our health. So I'll just advance here. I've had a little bit of trouble advancing my slides. Okay, so here we go. So fats, just to break it down a little bit more, we will classify fats generally as good or bad. Bad fats, and we've all heard the expression, are trans fats, and these include foods that are fats that you'll typically find in highly refined foods like cakes, pastries, deep fried foods. It's industrial processes have made the fats solid at room temperature so that they do not spoil, and you can have these very processed things like cakes and pastries on your shelf for a long period of time because they are filled with saturated fats, filled with trans fats, which are hydrogenated fats. So in industrial processes, we forced hydrogen ions onto those fat molecules, saturated them with hydrogen, in the process created trans fats, which give these foods a very long shelf life, for example, but then have very dire implications for your health. So trans fats are clearly bad, and in fact, they've been banned in certain restaurants. Saturated fats are classically lumped into the bad category, but we have examples now of where these things are in fact healthy, but these tend to be your animal fats, and I keep admitting people into this session. Fatty meats, butter, ghee, which is a very interesting product, or full cream dairy products. We typically think of these as unhealthy, and they probably are, but there are certainly examples of where saturated fats can be healthy. Then the fats that we unanimously claim to be healthy are the unsaturated fats. Okay, so there are double bonds between carbon atoms, often in one location or in multiple locations. So in multiple, that's the polyunsaturated fats. And here's where you get into your omega-3s, which are always healthy, but also your omega-6s, which are generally healthy, but have the ability to become unhealthy. So the omega-6s will often be in your vegetable oils, like a soybean oil or corn oil, whereas the omega-3s are going to be in your fatty fish or in algae. Monounsaturated fats are also healthy, and quite famously, these will be your olive oils and your avocados, things that we identify as particularly healthy, and in most nuts, in point of fact. So this is interesting because we know that nuts are healthy, and we learned that from the blue zone studies, that the longest lived populations on Earth tend to eat a small scoop handful of nuts every day. And in the Mediterranean diet, it's been validated in well-published studies that olive oil also is very protective against the development of cardiovascular disease and can be life-prolonging. And both of those are lumped into that monounsaturated fat category. Let's take a little bit more of a deep dive. Okay, the FDA, which is the Food and Drug Administration in the United States, banned trans fats in multiple restaurants in different locations. You cannot serve these things because of the health risks they present, and they expect that that will save thousands of cases of heart disease and thousands of lives because of that particular legislation, which I do feel is very good. Just because we're geeky and I'm going to geek out on you for a minute, what is the difference between a trans unsaturated fat, which is extremely unhealthy, and that's the molecule on the bottom here, and an unsaturated fat, which could be considered healthy? Remember, this is typically made by an industrial process, which has forced hydrogen ions onto the fat molecule in a way that they arrange oppositely. And when they're on the opposite sides of the carbon chain, that becomes a trans configuration, and this is what is exceedingly unhealthy, whereas its neighbor, where the hydrogen ions are on the same side of the carbon chain, can be a very healthy fat. So notice the subtlety in the biochemistry with dire implications for what happens in our bodies. And again, the saturated fats typically considered unhealthy, in meats, particularly processed meats, solid cheeses, things that should certainly be consumed in moderation. We have as much hydrogen as possible on the carbon chain of the fat molecule. As fats become unsaturated, now with double bonds between some of the carbon atoms, multiple carbon atoms. We're getting into the healthy fats. We're getting into the avocados, the fish, the nuts, the olive oils. So we'll appreciate some of those differences and realize the subtle biochemistry that's underlying those. Here is an example of a saturated fat, which is considered healthy, and that is ghee. And that's where we take milk as a dairy product. It's heated very slowly. We skim off the milk solid. So now we have a lactose-free anti-inflammatory superfood, where if that has been made from the milk of cows who were eating rapidly growing fresh green grass, we truly arrive at a superfood which has been thought to account for the extraordinary health of certain indigenous cultures who are eating this product naturally before modern conveniences overtook them. So I like to use a ghee in my coffee every morning. It's part of certain diet patterns, and we can think of that as a saturated fat, which is probably healthy for us. And then the omega-3s, which are always healthy, and the omega-6s, which are commonly healthy. Again, an omega-3 will have its first double bond on the third carbon chain of the fat molecule, whereas an omega-6 will have its first double bond on the sixth carbon atom of the fat molecule. So omega-3 and omega-6, we think of those things as so healthy. What are they? It's describing the location of the first double bond of the carbon atom. So again, very subtle differences in biochemistry that you would think would be inconsequential, in fact, having dire consequences for our health. So that should be hopefully enough geeking out, and we can start to get a little bit more practical. So
Love that, thank you.
Who is what and what's where? So omega-3s and omega-6s. So we think of our omegas as healthy, and certainly our omega-3s are always healthy. And there's really three omega-3s, and that is the ALAs, which is a vegetable source of omega-3, walnuts, chia seeds, vegetable oils. And then the EPA and DHA, which is that combination that is found in fatty fish. So when we think of fish being a rich source of omegas, we're talking about EPAs and DHAs. And if you want a vegan or vegetarian source of those molecules, they are found in algae, which is a reason why we can snack on seafood snacks, organic seafood snacks, and consider that to be a very healthy treat because it will give us the EPA and DHA. Just to skip ahead a little bit, we are learning that EPA is most beneficial for the heart, and probably DHA has its most benefit in the brain. So between these two omega-3s, you think EPA for heart and DHA for brain. Obviously, we want both of those organs to function very well, so you do need both of these, but we're learning that there's important differences between those two. The omega-6s also are considered essential. We must have these things, and there are consequences to having omega-6 deficiency. These in our modern culture show up mostly in vegetable oils, whether that's peanuts or almonds or sunflower oil. And as a consequence of that, they are abundant in processed foods. So processed foods tend to incorporate lots of vegetable oils, which are high in omega-6s. And as a consequence of that, in Western cultures, we are fed far too much omega-6 relative to the omega-3s that are available to us. So our omega-6 to 3 ratio or balance tends to be very lopsided in the direction of omega-6. Both are essential, but when that balance becomes too lopsided, that relationship becomes pro-inflammatory and contributes to cardiovascular disease. So these things that are considered good for you when they become out of proportion can then be bad for you. So lots of smoke and mirrors and challenging with some of these terms. For example, on the left column here, these are things that we should eat, and we'll see things that are found particularly in whole foods, but we'll see saturated fats, for example. Yes, we should have some saturated fats, but when those fats are saturated because they are hydrogenated, that means we've forced hydrogen onto them through industrial processes, they become very unhealthy. Monounsaturated fats, that's the olive oils, for example, has no unhealthy counterpart. So monounsaturated is always good. Polyunsaturated omega-6s, necessary for our diet, but because of industrial processes, but because of food processing, we become overexposed. And our overexposure to omega-6s through food processing means that they can, in fact, be bad for us. Trans fats, we always think of trans fats as bad, but let's remember that trans fats are, in fact, in their molecular structure, polyunsaturated, which is a word that we typically think of as good, so we can't trust that term completely. One term that is always good are the polyunsaturated omega-3s. That can never be confused with anything unhealthy. So you're safest with the monounsaturated and the polyunsaturated omega-3s in your diet. The other ones, we have to be concerned about sources. If they're from whole foods, there is a healthy benefit to them. If we are getting them through processed foods, chances are that they've developed some toxicity, and we need to be trying to eliminate these things. I think now we're done geeking out. So let's keep going here. Omega-3s, omega-3 fatty acids. Again, we said those are always important, always good for us. And there's literally 3 of them. There's ALA, which is this molecule found in plants. And then in fish oil, we have EPA, slight molecular variation, and DHA, slight variation, being the omega-3s that are available to us. So ALA is coming from everywhere through the different healthy plant sources, but then EPA and DHA being very specific to fish or to algae. So I'm just trying to advance here. There we go. So omega-3s, EPA and DHA, we want these things. We know they're in fish. We have the sense that we should be eating fish. And let's remember that small, short-lived pelagic fish, as they're called, are the best sources. So that's typically mackerel, sardines, and anchovies. These may not be the fish that you want to eat, but these are the best sources. One, because they are pelagic, it means they don't live near the bottom, they don't live near the surface, so they are most free from toxins, and because they're small and short-lived, they don't have time to accumulate toxins. When these fish go on to become the food of tuna, which also are good sources of the omegas, well, now whatever toxins these guys have incorporated into their system becomes concentrated in the larger fish. So as the fish gets larger, your chances of being exposed to toxicity goes up, making these little fish really the healthiest sources. So if you don't like eating those, hopefully the fish oil that you're enjoying did come from these sources, because that's going to be the healthiest one for you. And again, as a reminder, the plant source of EPA and DHA is algae, and we can be obtaining that in seaweed snacks. This is one that I like from Costco. You can buy these in bulk. They're fun to crunch on, and you can congratulate yourself on getting your EPA and DHA from that. Again, the last omega that we'll be exposed to the most is the ALA, a slight molecular variation, also proven to be heart healthy independently of the other 2. It will be converted in your body to EPA and DHA in small amounts. It's considered less potent. Nevertheless, individually, it is heart healthy, and something we should be also increasing our consumption of. And that's the ALA form of the omega-3s. We talked about the balance of omega-6s to omega-3s in our diet. And this is something that's gotten away from us in the modern age. We have traditional societies which ate diets that were rich in plants, fish, and meat, and dairy from free grazing animals, eggs from chickens who were fed plants that were high in omega-3s. And as a result, those dietary omega-6 to 3 ratio was about 2 to 1 to 1 to 1. So a nice balance between 6s and 3s, with the 6s maybe twice as much. Move us up to modern societies, and we were supposed to have made progress, and now we're eating processed foods which become abundant in the omega-6s because they're processed vegetable oils that we're using to make these processed foods. So industrialized regions of Europe and the United States you can get a dietary omega-6 to 3 ratio of 16:1 on average, way too high from what traditional societies were experiencing, what's healthy for us. And that's going to become reflected in your body composition and then the omega ratios in your bloodstream. So that imbalance, both of these things independently being good for us, but that imbalance becoming a source of inflammation and chronic disease. So we can get people who are grossly unbalanced with ratios of 10:1 to 50:1, semi-balanced when you're 9:1 to say 3:1, but us really wanting to get down to the 4:1, 3:1, 2:1 ratios in our blood tests to minimize the systemic inflammation that's present in our bodies. So please tell me what to eat. Polyunsaturated fats in our diets. We want to eat foods that are high in omega-3s because we have a hard time getting these. Okay, so these become our fatty fish, salmon, mackerel, sardines, lots of green leafy vegetables, the broccoli, the spinach, and nuts, walnuts and linseeds in particular. Really think of walnuts as being a great source of omega-3s, and also chia seeds, which is something I'm using for my breakfast quite frequently. So eat lots of omega-3s in a way that we can achieve an ideal 1:1 ratio with the omega-6s, and we're going to find those in vegetable oil products like margarine. So margarine's not something we want to be eating. I'd much rather eat a very high quality butter. And then all of these other processed foods that sneak in on us. And even if you're not eating something that looks obviously processed, so many of the ingredients in the otherwise seemingly healthy foods that we eat do contain processed components which are exposing us to the omega-6s. So our goal is to make these things small and these very large in our diets. Challenging to do. Exemplified well in, say, a Mediterranean diet, where a traditional Mediterranean culture is eating lots of fish, they're eating lots and lots of fruits and vegetables, they're eating lots of nuts, seeds, and legumes, they're having salad, and they're using olive oil for their salad dressing, they're cooking with olive oil, and they're having meat occasionally, fish, chicken maybe once a week, or red meat maybe once a month, but not much more than that, and certainly not processed. And there's good evidence now for the heart healthy benefits of a Mediterranean diet. And this is a study that was long in the making. New England Journal of Medicine 2018, finally, after being published in 2013 and then retracted for faulty statistical analysis. And now it's a part of our out of our research body that we can truly draw on. But this study attempted and succeeded in validating the heart healthy benefit of a Mediterranean diet. And what's interestingly is they fed one group a traditional Mediterranean diet, olive oil, fruits, nuts, vegetables, cereals, fish and poultry, low in dairy, red meats, processed foods, sweets. Famously, wine in moderation consumed with meals is part of the Mediterranean diet. But then beyond kind of that collection of that dietary profile, they had two focus groups. One had extra nuts, 30 grams a day, 15 grams of walnuts, and then 7.5 of hazelnuts and almonds. And then another group had olive oil, generous olive oil, extra virgin olive oil. Each participant got 1 liter a week with the requirement to consume at least 4 tablespoons per day. So what happens? You give this to men 55 to 80, women 60 to 80. They don't have cardiac disease, but they are at risk, meaning that they have diabetes, other risk factors such as smoking, high blood pressure, high LDL, low HDL, they're overweight, or they have a family history. And you give them a controlled Mediterranean diet, or a diet rich in nuts, or a diet rich in extra virgin olive oil. You follow them forward in time for 5 years. We're talking 2,500 people in each group. And you see, here's adverse cardiac events. And just a standard heart healthy diet, you get this rate of cardiac events. But in that group that's eating extra nuts and extra olive oil, those rates of cardiac disease, whether they developed a heart attack, stroke, or they died from a cardiovascular cause, much less. So not only the Mediterranean diet, but also the olive oil and also mixed nuts. Both of those, you remember, are the monounsaturated fats, except for walnuts, which are well represented, but that being a good nut source of omega-3s. But which is the polyunsaturated, but we're really tapping into those two monounsaturated fats in the Mediterranean diet, being those things that have extra health benefit in terms of cardiac protection. So that said, we kind of know what to eat now, and we kind of understand the distribution of fats in our diet. And then that brings us really to this question of cholesterol. What's cholesterol and how is that different from fat? Well, you can see cholesterol is a waxy fat-like substance that's found in the cells of your body. It's found in your bloodstream. Our body makes it. You need it for hormones, vitamin D, other essential molecules. Our body does need cholesterol. You can see cholesterol is made of rings of carbon rather than straight chains, so it's molecularly very different. Most of it comes from our liver. Okay, our liver is pumping out LDL cholesterol. We'll recognize that as bad cholesterol. That's a clump of triglycerides and these cholesterol particles with protein tags that tell the walls of our arteries to incorporate them into fatty deposition in our vasculature, which causes cardiovascular disease, legs, brain, heart. Good cholesterol, HDL cholesterol, is leaching that cholesterol out of those plaques and returning it to the liver to be metabolized and eliminated. So our liver is making most of our cholesterol. It's true you can eat cholesterol that will raise your cholesterol levels, but if you eat cholesterol, your liver will just make less. And if you don't eat cholesterol, your liver is just going to eat more. So how much cholesterol does your liver make? Well, that's going to be determined by your genetics and also your liver's response to your diet in general and to the amount of exercise that you're getting, okay? But we don't have a ton of control, direct control over cholesterol because it's really under the independent control of our liver, which we have a limited ability to really influence. So cardiologists are constantly measuring cholesterol levels. We want to know your total cholesterol, your HDL, good cholesterol, your LDL, or bad cholesterol. We can also measure these triglyceride particles, which are contained in the HDL and the LDL. Okay, here's what, these are in US units, so excuse me for our international audience, but these can be converted. So we have desirable levels of LDL, HDL, borderline high, and then frankly high levels of cholesterol. You know, when your LDL is getting up to 160, 190, we're like, wow, that's frankly high. When your triglycerides are above 200, that's frankly high. And when your HDL is less than 35, it's like, wow, you're not getting much protection there. And this pushes us towards serious intervention, both in terms of lifestyle reform and probably medications. So do our foods impact our cholesterol? Absolutely, because they influence the liver through indirect processes, but they do. So again, those healthy foods, the fatty foods, the salmon, the tuna, the olive oil, the whole grains, the avocado, the beans, the berries, the nuts, the dark chocolate, green tea, citrus fruits, those are going to bring down your LDL cholesterol. And a friend of mine actually here in town just brought his LDL down from 250 to 98 with diet reform alone, which is a remarkable accomplishment, I think, with diet and really focusing on eating just these things and eliminating all the garbage. So really impacting LDL cholesterol in an important way. But for most of us, there is going to be a genetic component to our cholesterol levels that we're not going to overcome. And so many people will, in fact, need cholesterol lowering medications. And that's really because of this phenomena of what we call familial combined hyperlipidemia, meaning this is your non-specific genetic contribution to cholesterol, 500 plus genes contributing to this. You never know which ones are at play in you, but this is the person who kind of has the family history of early cardiac disease, now has high cholesterol and is at increased risk. It's because of this genetic predisposition mediated through 500 plus genes. Who knows which ones are active in you? It isn't worth figuring it out. Just if you have this risk profile, you deserve to be treated so that we can prevent what's happening on the bottom, and that's the buildup of these cholesterol plaques in the arteries of our hearts or extremities, for example. As those plaques grow, the room for the blood gets smaller, and then what can happen catastrophically is that lipid plaque can rupture, and when it ruptures, a blood clot will immediately form on the site of rupture, and that blood clot can immediately occlude whatever is left, and that becomes your heart attack, that becomes your stroke. It's when that cholesterol plaque ruptures. So we have high levels of cholesterol exacerbated by inflammation, other cardiac risk factors contributing to this disease, with our anti-inflammatory processes counteracting that. And we're just trying to get through life and die of other causes without this taking place. Okay, so we can do that by controlling our lipid levels, controlling our diet, minimizing inflammation, minimizing our other risk factors, and in point of fact, when those things aren't enough, taking medications. So, because so many of our patients are on, and really, let me know if I'm going too slow or we're running out of time here, but I feel like I get carried away. But medications lower your cholesterol. I'll just review major categories because so many people are on these or need to be on these. And as you can imagine, without surprise, most of them act on the liver because the liver is where cholesterol is made. So we have the statins, very famously, so many people are on statins, whether it's Lipitor or Crestor, and that blocks your liver's ability to make cholesterol. If you cannot tolerate a statin or isn't enough, because statins tend to cause muscle pain and cramping and profound fatigue, we can move on to the PCSK9 inhibitors, which block the degradation of LDL receptors so that your liver is able to pull more LDL out of your bloodstream. And that's very good. Ezetimibe or Zetia blocks absorption of dietary cholesterol through your gut. Here's a new kid on the block that we love, Nexletol, which is another mechanism for blocking your liver's synthesis of cholesterol. So very much a statin type mechanism, but without so many of the important side effects. And when that is combined with ezetimibe, which it often is, we get Nexlizet. And these are new kids on the block, still very expensive and not even close to being generic. And then we have our fibrates, very good for triglycerides, again, hauling that stuff out of the blood, sending it back to the liver, and forcing it to be disposed. So guide to statin therapy. So many of us are on statins. You can have your high intensity statins. There's only 2 drugs which qualify as high intensity statins, and that's your atorvastatin and your rosuvastatin. Okay, this is your Lipitor, this is your Crestor at adequate doses. If you lower the dose, those same drugs are now considered moderate intensity statins. And then you have a host of other molecules which will never qualify as high intensity statins. They are moderate intensity. And those fellows at even lower doses will become your low intensity statins, almost useless. So we treat with moderate intensity and high intensity when it is needed. So who should take a high intensity statin? If you have coronary disease or cardiovascular disease anywhere in your body, you should be on high intensity. If your LDL is really high, over 190, you need to be on a high intensity statin. If you have diabetes as a risk factor and you're not too young, not too old, with really any LDL, just the presence of diabetes, you should be on a high intensity statin. And if you don't meet those categories, but your estimated risk from a host of other things is over 7.5% over 10 years, we're going to say you should be on a high intensity statin. So in cardiology, we're spending a lot of time trying to identify these individuals and get them on appropriate therapy. Now, those are the medications. What else can we do? We know that these fatty fish are so good for us, and if fatty fish are so good for us, then why can't we take fish oil as a supplement and have the same benefit? Good question. It seems like it should work. Fish oil has been the frustrating story of cardiology, trial after trial coming up negative, not showing benefit when you think it should, and it makes so much sense. The two pharmaceutical grade fish oil supplements that we have available right now, the first was Lovaza, okay? Lovaza, EPA, DHA, very pure stuff, prescription grade fish oil. 1 capsule contains 1 gram, really lowers your triglycerides like fish oil should do, and benefiting your cholesterol in other ways. Interestingly, when Lovaza, which is both EPA and DHA, like a real fish, it will actually increase your bad cholesterol or your LDL while it's dragging down everything else. So that's a negative safety signal. And in point of fact, when we studied Lovaza, 2 trials, no benefit in preventing heart attack, stroke, or death, no reduction in heart attack, stroke, or death from cardiac causes in individuals at some risk, but without cardiovascular disease. So it did not prevent it. Interestingly, only 1 gram per day, which might have been too little, over 7 years, over 5 years, 1 gram a day. I wish we would have studied higher doses, but we have those 2 negative trial results. It moves us to our most recent fish oil supplement, which is a fish oil derivative, which contains only EPA. They've left the DHA out entirely, and that is Vasipa. Okay, so icosapent ethyl at doses now that are recommended at 4 grams per day. So here again, to summarize, we have Lovaza, EPA and DHA. We have Vasipa, which is EPA only. The Lovaza will decrease triglycerides, but unfortunately increase LDL, whereas the Vasipa will decrease triglycerides, but not as much. Both recommended at 4 grams or 4 capsules daily. In the Vasipa trial, finally, studying patients with known cardiovascular disease or without cardiovascular disease but high risk at 2 grams twice daily or 4 grams per day total. Finally, with the Reduce It trial published 2019, we have something, a medication now effective in reducing heart attack, stroke, anginal chest pain, and death from cardiac causes. So it's the fish oil isolate EPA at a dose of 4 grams per day. Again, I'm treating patients with this all the time. I prescribe this to several individuals today. For example, we won't know what their EPA levels are. We won't know what their omega-3 levels are because we have no way of knowing those values with our laboratory tests. Nevertheless, at that full dose, we do expect cardiovascular benefit. So who should take Vasipa, for example? Lots of agents have weighed in. The American Heart Association says it acknowledges, first of all, that this is your first non-LDL focused lipid therapies, okay? So very different from the statins and the other drugs. We're not focused on LDL, we're focused on omegas. It's the first one to demonstrate cardiovascular benefit, and it should be first line in anyone with type 2 diabetes and coronary disease who also has high triglycerides when they're already on a maximally tolerated dose of statin and have made appropriate lifestyle changes. The Europeans also say in patients with cardiac disease and high triglycerides, because the fish oils lower the triglycerides so effectively, and for the American Association of Endocrinologists, if you are high risk, but you don't have to have cardiac disease, as long as you have high triglycerides, you should be on this EPA derivative. So anyone with high triglycerides, you can make an argument that they should be on it. And certainly individuals with established cardiac disease and also elevated triglycerides should be on Vasipa, which leaves, of course, us with the question, what do we do with the patients who don't quite fit those definitions? They are high risk, but their triglycerides aren't high, too high, or they have coronary disease, but their triglycerides aren't too high. Would they also benefit from omegas? Of course, I believe that they would benefit from omegas. We just don't have proof as to what they would benefit from. So we don't have a mandate to prescribe or recommend omega supplements to those patients who don't fit those very strict definitions, which is just the way medical therapies lumber forward, only reaching out to those who meet fairly strict definitions. But let's acknowledge at this point, very high level, supplemental fats to protect against coronary disease. Olive oil, 4 tablespoons daily, that's 60 grams a day. That's oleic acid, monounsaturated, and omega-9. We know from the Mediterranean diet studies in 2018 that olive oil protects against coronary disease. And now we have this result that omega-3, the EPA, hefty dose of 4 grams daily of VASIPA will protect against coronary disease. So we have these 2 supplemental fats that we know we can draw from. So should we be consuming EPAs? Seems like we should from whatever source we can get them. Should we be consuming olive oil? Seems like we should from whatever source we can trust, because olive oil is smoke and mirrors in terms of quality and legitimacy and rancidity and whatever else you want to throw at that problem. But a high quality olive oil should be part of our program, which I think everyone here on this forum has some interest in the balance oil from Zinzino. And so knowing what we just talked about, let's take a look at the product label and see what this particular product contains. And there we go. So everyone, all these pictures are in front of it. But at the 2.5 teaspoon dose, which is probably a lot of people who weigh 175 pounds. I'm over 200 pounds, so I'm at the 3 teaspoon a day dose. But at the 2.5, let's see what's in here. Omega-3s, 2.5 grams a day. And remember that EPA said 4 grams a day for VASIPA in the clinical trials. So we're not at 4 grams per day, but we're pretty good. And we can appreciate that most of what's in that omega-3 is EPA, okay? So 65% of the product is EPA as opposed to DHA, which is a higher ratio of EPA than, say, Lovaza, which was our disappointing fish oil supplement, nevertheless very good at lowering triglycerides. But then we can rationalize a little bit and say, hey, look, it's not all about the heart. We also have brains, and we need our brains to be healthy, and brains benefit from DHA. So even if that isn't the one proven to be heart healthy, probably prudent to include DHA, appreciating that the heart is seemingly favored in this particular formulation. And then we saw that the Mediterranean diet had benefit from olive oil when it was consumed in large amounts. And so here at this 2.5 teaspoon dose of balance oil, for example, we have 4 grams of olive oil. Now, is that a better olive oil than the olive oil in the Mediterranean diet? They didn't specify what they were taking. We don't know much about it, except that it was 4 tablespoons a day, which is almost 60 grams a day. So it's a lot more. But nevertheless, we know it has benefit, and we can appreciate that that we are getting olive oil as well, which we have proof is beneficial for our cardiac health. So a nice combination of fish oil. I like the combination of EPA, DHA, with olive oil, so we can appreciate that these are omega-3 fatty acids, and the olive oil now an omega-9 fatty acid. These are the polyunsaturated. This is a monounsaturated, so a very different molecule. This has proof of cardiac benefit. This has proof of cardiac benefit. We're approaching the doses that were studied in clinical trials. We're getting a nice hefty dose. I don't think we'll ever get close to what was actually taken by what was actually consumed in the Mediterranean diet trial, but this does give us plenty of room and liberty to use extra olive oil above and beyond what's in the supplement product for our cooking and for our salad dressing, which of course we should be doing. But this seems to be a healthy product. What I like about it, again, and what we're missing in daily clinical practice are blood tests to measure our omega levels and our omega 6:3 ratios. This is not available to me in clinic. I would love to test those patients who are receiving Vascepa before and after to see how those ratios and levels change, but I don't have access to that. In the Zinzino program, there is a blood test provided. As most of us know, it's a finger stick, very much like a diabetic program, and then you drop the blood from your finger onto two spots on the cardboard. You try to get it to saturate, send it away to the lab for analysis, and you can check your levels and your ratios at baseline, and then after 4 months of the product, which is what is recommended, to see how that difference has manifested in you. So very interesting. Do we have proven benefit of this formulation? No, we don't have proven benefit, but at least we have a laboratory test that will confirm for us that our levels are actually changing and moving towards levels and ratios which have been demonstrated to be healthy and which we know to be healthy from other, basic science trials. So that's encouraging. And that is something that's unavailable for other omega supplement programs. I have taken fish oil supplements for years. My ratios, right up until the time I took this test, and my ratios were quite disappointing. And we suspect that that's true for other people taking omega supplements. And so many of my patients are doing that, and they're spending substantial money doing that. We don't have quality control over those products. We don't know if they're becoming rancid as they sit in our shelves, often for months at a time. And we don't know if the purification processes, especially for fish oil, are degrading so much of the benefit that is found in the fish itself. So smoke and mirrors, but for those other products, without a test, we're really taking them in blind faith. And at least on the Zinzino program, we can test our blood before and after and quantify a meaningful change. So here is my test initially, and this is somebody who is taking a fish oil product, eating lots of avocados, and also consuming olive oil quite regularly, coming out to be quite unbalanced with omega-3 index ratio that is insufficient, at risk for my mental strength, cellular fluidity. I achieved some good arachidonic acid levels, which is reassuring because that will help me promote inflammation, which we need. So I have this initial result. If I was presenting several months from now, I would show you the final result, but I'm probably a month into the program and looking forward to seeing what the repeat testing shows. Things that I've noticed initially is the quality of my skin is so much better. I always had very torn and painful skin at my fingertips my entire life, which I could never explain, and that has completely disappeared, which is very reassuring for me. So I'm in the program. I'm looking forward to the final result. I'm taking my 3 teaspoons per day dose of the stock-loaded of the very regular balance oil, nothing fancy, no additives, and I'll be interested to see how that shakes out for me. And I'm excited about that product, appreciating now finally the independent benefits of the fish oil, the independent benefits of the olive oil, the doses where those benefits occur, and seeing those things mirrored in the Zinzino balance oil product. Of course, those clinical trials tell us never to extrapolate results from that trial to other things that we're doing. In point of fact, in real life, we're always extrapolating, and we're always extrapolating trial data to try to apply it to our patients who never fit the exact description of study populations. And that's the reality of clinical medicine, and my rationale for being excited about this particular product and the blood test that it provides. So again, dosing recommendations are based on weight. It's 0.014 teaspoons times your body weight in pounds. So if you're 110 pounds, that's 1.5 teaspoons. If you double that to 220 pounds, you're 3 teaspoons daily, and everything in between. I appreciate that it's not encapsulated. It is a free-flowing oil in dark bottles, which should protect that oil. There's rationale that the olive oil will help protect the fish oil from becoming rancid, so it preserves its freshness and its quality. And we can appreciate that interaction, understanding that those are very different molecules. It's a monounsaturated fat, hopefully helping to protect a polyunsaturated fat. I think for some laboratory reasons we're not going to appreciate today. But we're expecting our EPA and DHA levels to improve, our ratios to normalize, and we'll prove that with our blood tests. So we'll expect polyphenol support, protecting us from inflammation. I'm hoping for improved brain function, improved or normal and preserved heart function, as well as benefits in terms of our immune system. So we're looking for those anecdotal reports before any large trial results become available with this particular product. We have several different flavors that are available to us. Find the one that you like. There's a vegan option, and as well as an option which is more concentrated in polyphenols, which may apply to people with certain medical conditions or metabolic profiles. So there we have it, your cardiologist high-level view of fats, lipids, and therapies for cardiovascular disease. I hope that made sense. I've been talking a blue streak. I can't even quite remember what we said.
This is so great. Okay, I'm going to move over to Deb's screen here. So I'm so glad that you've put your website up, because I was going to just refer everybody to visit jamesknellermd.com and follow him on his YouTube channel. He actually has, like, just, you know, if you've got a weak stomach, definitely go there. But he does surgeries, which are amazing. We do have some questions here for you, Dr. Kneller, if you've got time.
Yeah.
Okay, awesome. So Dr. Sharon had asked, her question was, Dr. Sharon had asked, would you consider that the benefit of omega-3 fatty acids among individuals with increased cardiovascular risk are offset by a risk of atrial fibrillation? And I'll actually unmute Dr. Sharon here. I'll ask to unmute her so she can actually even specify that a little bit further.
Yeah, that's a good question. And that
she's unmuted. Yeah.
Both the Lovaza and the Vasipa did have a signal for higher rates of atrial arrhythmias, particularly atrial fibrillation. Atrial fibrillation is my passion, an area of specialty. So that's interesting that could predispose to AFib. I'd like to think that preventing cardiovascular disease is more important. And once someone has some AFib, if they have more, it doesn't change a lot what we're going to do for them. It was too bad to see that signal in somebody who really struggled with AFib, which a lot of my patients do. Probably more likely to steer them away from these things because it would, make it worse. Or there's the safety signal that it could exacerbate the atrial fibrillation. But I think if you're truly at risk for cardiovascular disease, I would take on a little bit more AFib to get rid of a little bit more atherosclerosis. That's kind of how I would toss it up. But that's a good point, and something I didn't mention and should have mentioned is that you do get the atrial dysrhythmias with the fish oil supplements, which is something that I don't think we don't understand right now. But
okay, I don't know. Was there a follow-up to that, Dr. Sharon? That answer the question? I think it must have. Okay.
Where's Dr. Sharon from?
Dr. Sharon is in Sudbury, Ontario.
Oh, cool.
Yeah. We're going to connect you with her shortly. So I'm looking forward to that, actually, but we'll do that. We'll do that. So we have questions. Oftentimes this question comes through, if somebody is on a blood thinner, is it safe for them to be taking a omega-3 or a balanced oil supplement?
I would say the short answer is yes, it's safe, unless you really struggle with bleeding and bruising. But if you're having an uncomplicated time on your DOAC therapy or on aspirin, I would go ahead and take it, appreciating that your blood is going to be a little bit thinner, and it's hard to know how much thinner and in what individual.
That kind of gives me a segue to another question that came in. And if somebody wants to ask this go ahead and like wave your hand or something. Another question that came in was regarding aspirin, and it said, would you, oh, where is it now? What's better to reduce a heart attack? Would you recommend aspirin or would you recommend omega-3 supplements?
If you've had a heart attack?
In the reduction of, reducing the risk of a heart attack.
I think if you have established cardiac disease, meaning we can measure appreciable atherosclerosis kind of anywhere in your body, you need to be on your aspirin. And that's because that final sort of catastrophic event is when the plaque ruptures and then the blood clots. So then the platelets see that the soft underbelly of the ruptured lipid core, and all the platelets aggregate there, and then this clot mushrooms, balloons, and suddenly completely occludes the vessel, which otherwise was transporting blood just fine. So the aspirin is to counteract the platelets. So if you do have that plaque rupture, the aspirin is going to be there to try to prevent the platelets from aggregating on the clot. If the omega products and the medications that reduce atherosclerotic burden and try to stabilize these plaques so they don't rupture and shrink them so they're not as big, that's a completely different process. So I would use both of them for different reasons. But I would be remiss to let anyone off their aspirin therapy.
Perfect. That makes sense. Thank you. The next question that had come through, Melanie. Oh, Melanie asked a couple of questions. So one of them was, what should someone do who has low blood pressure and can't get it to go up? She said she believes that they have been part of chemotherapy treatment.
So you have low blood pressure and you can't get it to go up. In ways, it's a good problem to have because most people have blood pressure they can't bring down.
Right.
But there are people who get low blood pressure and are symptomatic from low blood pressure. That can just be from so many things. I'd say sort of poor vascular tone for whatever reason is a large contributor. Easy things to do are to try compression stockings, either knee high or thigh high, and that may give you the pressure you need to sort of function and not feel like you're gonna pass out or maybe prevent you from feeling faint. So that's an easy mechanical thing you can reach for. We treat with midodrine sometimes, which is a medication which will increase arterial or venous tone in your extremities, and that can prop up your pressure, and that can be enough to make a difference for some people.
Okay.
Those are the two things I would reach for first.
Yeah, that's really good to know. I've had low blood pressure my whole life, and I've never considered compression stockings. It kind of may counteract my fashion sense, but I will take that under consideration, doctor. Thank you. Another question that had come in.
They can be fashionable.
They can be fun. I'll bring it back. There's a whole new market for us, Dr. Kneller. Okay, so another question that had come in was, often heart attacks are mostly male. Is this true? Is this a stereotype? Is that because of the lifestyle choices of a man, or is it different physiology? Or is that a statistic anomaly?
I think it's mostly, at least traditionally, it's lifestyle and stress. Probably, I think historically is a little bit more in men. Genetically, I'm not sure they're really that much more predisposed, but there probably is. Just the fact that you're male makes you a little bit higher at risk. It's just like we include female sex as one of the risk factors for developing blood clots due to atrial fibrillation. You know, it's there in your CHA2DS2-VASc calculation. If you're female, you get a point that puts you closer to needing blood thinners. And I think the male thing is that way too. But I think a lot of it is males tend to be higher, they tend to be more risk takers, they tend to be higher risk. That includes with their lifestyle, diet, and exercise. And then some higher stress stuff. You know, it's often the male who's out there first thing in the morning shoveling snow at a time. Oh, that's a classic time for heart attacks. You know,
really, Monday morning, he's all mad. Yeah, it makes sense.
Your cortisol, you're waking up, so your cortisol levels are starting to surge, and that's gonna make your heart beat more forcefully. It's gonna constrict your blood vessels a little bit, And at that critical time, you're going out and working hard, and it's the perfect storm for heart attack in someone who's predisposed. So
Can I ask you a question?
a little bit is cultural lifestyle, probably a little
Makes
bit
sense.
genetic.
Awesome, thanks.
Hi, Dr. Kneller. I have
Hey.
a question for you from Gail. Would low oxygen levels improve with omega-3/6 indirectly or directly?
I'm going to say hopefully, maybe indirectly. All you can do is try.
Okay.
You know,
That's fair.
if your lungs are a little bit inflamed and so they're not transporting oxygen as well, and if the omegas reduce that and allow them to function incrementally better, you'll get higher oxygen levels. If your blood vessels relax a little bit in the presence of the omegas and you circulate a little bit better, and things get around the block and back to the lungs a little bit faster or a little bit more, then the oxygen levels in your blood will go up.
Mhm.
Sometimes they're low just because your circulation's so slow that your tissues have more time to pull all the oxygen out that they can. And so anything that improves your circulation would tend to improve the average saturation.
That makes sense.
But that's all kind of Monday morning quarterback stuff, trying to guess what's going to happen in any one individual, which is
Okay. We have another question here from Marcia. Just to double check, I have atrial fib. Would I be wise to go off the oil, or does it depend on the severity of the atrial fib, or should I reduce the amount I take? So we've got a couple of questions there.
yeah, that's interesting. In some of the Omega trials, rates and occurrences of atrial fibrillation went up. I think it's a clinical decision, how much you're having, how bad it's bothering you. Are your antiarrhythmics working? It's probably not going to change your decision or need to be on a blood thinner. I think it's going to be a really individual decision that we'd make based on those things. I'd say we probably can't let you off your blood thinner. So how much AFib you have really doesn't matter, depending on how much it bothers you and depending on how well your medications are controlling you. So if all of that's fine, I would tell you to go ahead and enjoy the other benefits of omegas. But if we absolutely couldn't get in control of your AFib and we're struggling endlessly, and there's lots of people like that, I'd say stay away from it, because this is your most pressing problem right now.
So I'm curious about that. So when we hear something like that, do you as a physician also recommend that they stay away from fish, for example?
No, we're not there. And honestly, these signals are pretty new, and I don't hear anyone stretching that out to say, oh, don't eat fish just because this pharmaceutical fish oil derivative gives a little bit more AFib.
Okay.
No one's walking it back quite that far right now.
Yeah, I'm curious. Okay, so here's my last, well, maybe it's not my last, it's my last question, unless another one pops up here. So I have been a vegetarian for 40 years at least. And I was very unbalanced. I started the Balance Oil. It is a fish derivative. When you talk about seaweed snacks, how much do I need to eat of seaweed snacks? Seaweed. Can I say it? Sneedeweed. I'm so nervous.
I know.
What?
We have a handsome young doctor.
Right. How much do I need to eat? Seriously, if I was to go and head to Costco and buy the seaweed snack, am I really going to be able to eat enough to get my DHA and EPA where I need it to be?
I don't know. I do not know how much you're getting. I'd have to research.
You don't know how much I need to
try
eat.
to walk that back, figure that out. I don't know.
Okay, that's okay.
I would maybe look at a traditional Japanese diet, and these people have some extraordinary longevity, and I would try to figure out how much they were consuming.
Right.
Is it really that much? And I'd kind of judge it off that. You know what I mean? If I was doing as much as traditional Japanese diet, I'd feel pretty good about myself.
Okay, so I'm probably best to stick with my supplement as well then.
I'd stick to yours. I would keep the supplement, but maybe throw in some seaweed.
I'll get stuck in your teeth.
Oh, I know, between your teeth, right? Endlessly.
All right, there's one more question. Do you want to do that one?
Sure. What part do polyphenols play in reference to heart disease and balancing the omega-6, 3 to 6 ratio?
Oh, that's a good question.
Wow, I might punt that one over to Mick. My understanding.
We can unmute Mick too.
We didn't get to polyphenols. That's another class of molecule that is found in olive oils. It can have, it is just another compound that is strongly anti-inflammatory for reasons I can't say off the top of my head. So we try to eat foods that are high in polyphenols, and we're aware that
Chocolate
these
and
things that
wine,
are
you told me.
all
I heard
this
it
stuff
from the
in our
doctor.
diet to try to minimize inflammation. But again, it's hard to quantify, and I don't have a good idea of how much is enough or
Mm-hmm.
or what a little bit extra, because Zinzino does have the product that's high in polyphenols.
Yeah.
What your doctor would probably say, if you'd had a head injury or you had bad coronary disease or whatever, they'd probably say you need to have the strongest one possible, and that's probably wise, but it's all, I don't have a very quantitative reason to say that, honestly.
Okay.
Nick-
Dr.
Nick
Jordan,
probably
did you
knows a lot
want to
more.
jump in there, Dr. Jordan, or are you?
Thanks. Yeah, so what Dr. Kneller talked about with the conjunction of the omega-3s and the omega-9s in there as well. So it's, from a polyphenol point of view, is that it's a really, as you already mentioned, really rich antioxidant that we don't tend to find in high concentrations, depending on how a lot of vegetables and fruits and things like that are grown these days. So that's where a lot of that's lacking. But what I've found is that the polyphenols are helping with the absorption of the omega-3, particularly through the gut lining as well. But they also have that added benefit as a standalone, is that they're actually protecting against oxidative damage and stress at a cellular level as well. And obviously with the new version of the Balance All Premium, we now have that 4 times the polyphenol content of that as well.
Awesome.
Right.
Thank you. Okay. Did we have any other questions that come through? This is your opportunity to you're so lucky to be able to have a.
We were so fortunate tonight. We had 3 doctors on tonight.
We did have 3 doctors on. That's fun. It makes me feel so much smarter.
I'm glad it made you feel smarter.
Do we have any other questions? Because feel free to go ahead and raise your hand if you like,
We have a few minutes. So
if not, we can wrap this up and we can definitely refer you to Dr. Kneller's website.
Mm-hmm.
Oh, we have another raised hand. Hang on. Can I figure this out? I'll let you figure this out.
Okay.
Ask to unmute.
I have to find him here.
All right. You can type your question there if you like, Jason. Or we'll try to unmute you to ask the question. Oh, you're unmuted.
What part do polyphenols play in the reference to heart disease and balancing omega-3 to 6 ratios?
Oh, that one was just answered. It was just answered like a quick minute ago. I'll give you the replay.
Yeah, Mick took that on. He said partly it helps with the absorption of the omega-3s in the first place from your gut, which is important because if they don't make it into your bloodstream, then they're going to be useless. We talked about deficits in traditional vegetables related to I think some of the modern food growing techniques and depleted soils where foods don't have the polyphenols levels that they once had. So when we're eating produce from the grocery store, we may not be benefiting the same way that folks eating the same thing 100 years ago or 200 years ago would. And therefore we need to supplement with these things to get the anti-inflammatory benefit that was probably part of our diet previously. But
Awesome.
I don't know if that's summarizing a little bit what you had said, Mick.
Yeah, no, 100%. So as far as the 6:3 ratio, that's really controlled by the omega-3 component of the balance all, whereas the polyphenols, the vitamin D that's added, are definitely bonuses to actually help the absorption at a much higher level as well. So the polyphenols in themselves are not so directly affected, or won't directly affect the omega-6 to 3 balance. It's about raising your omega-3 levels, so those that omega-6 to omega-3 ratio is improved.
Okay, we have a couple of questions coming in on Facebook, and then we will, I've asked everybody to unmute. So after this question, well, oh, hi, Ken. After this question, we will, okay, go ahead. Do we have the question?
Ken needs to mute himself. I'm not seeing a question on Facebook.
Actually,
Susan, here we have a
Karen, if you can
question.
see that, you can go ahead and ask that question. Karen.
She asked about the eyes, omegas and eyes. What about omega or balance oil helping eye issues, glaucoma?
Oh, we've got, so the doctors are welcome to answer that one. We also do have an optometrist that will be joining us coming up too, that will kind of talk a little bit more about optical health. But Dr. Kneller, if you want to take that one away, feel free.
Yeah, I'm gonna say it's good and it's healthy and helpful. How much is a question I can't answer, but glaucoma I'm not sure about, but I think cataract formation and macular degeneration, some of these things that are related to inflammatory, I think oxidative damage in the nerve fibers of your eyes over time, that's one of my motivations to take a lot of antioxidants. And
Yeah, how do I get on the type of screen here?
Omegas being one of those things and protective. So I'll just say stack it and pack it, but get high levels and as much as you can and expect some benefit. But how much benefit in any one person, I wouldn't be able to say.
Yeah, that's fair.
And for all eye pathologies, I'm not sure. Glaucomas, which is an increased pressure in your eyeball, I'm not sure. That's probably a pretty different mechanism from, say, macular degeneration or cataract formation, which I think is a more inflammatory process and a lot more common. So common things being common, I think the omegas have the bigger role for those. Glaucoma, I really would feel uncomfortable saying too much.
Yeah, that's awesome. I am so grateful. I am confident that we will hopefully be able to get into your schedule again at some point. Maybe next time we can talk about olive oils and polyphenols, because that's one of our favorite topics as well. If everybody would like to unmute themselves, I think we have unmuted most everybody. And I think we have. I think there's the odd one that we muted. We'll go right ahead and give Dr. Kneller a round of applause.
Thank you again, Dr. Kneller.
Thank you. We are so
Thank
grateful
you.
on behalf of the Omega
Thank
Revolution
you.
to
Thank
have you.
Thank you.
Thank you, Mitch.
Thanks a million.
Thanks
We're
again.
really grateful. So this will be, this is recorded. We'll be certainly sharing that on Dr. Kneller's Facebook page, his YouTube channel, and you'll be able to catch that on the Omega Revolution page shortly as well.
Awesome.
Okay. Thanks again,
Thank you,
everybody.
Ray.
for
Thank you,
coming
Debbie,
out.
for setting it up.
Thank
really
you.
well done. Thank you. You guys
Take
did
care.
great. Look great.
Good night.